Hello and welcome to the APAPP podcast. My name is Rebecca Priebe. I am an acute care nurse practitioner and interventional pulmonary in Detroit. And I'm also the chair of the interventional pulmonary division within the APAPP organization. I'm excited to be here today. We are discussing lung nodule management and lung cancer screening. There are slides associated with the podcast today. So if you're unable to see them, you can feel free to jump into our YouTube or Spotify later to check those out. Today, I am pleased to be joined by Tammy Welch. She is a physician assistant who is the Early Pulmonary Cancer Detection Program Coordinator for lung cancer screening and incidental nodules at Frederick Regional Health System in Maryland. Our discussion today will center on pulmonary nodule identification, challenges associated with nodule and lung cancer screening programs, the critical role of an advanced practice provider in these programs, and the integration of Nodify Lung, which is a blood-based test developed by Biodesix that supports the clinical decision-making to help stratify the risk of malignancy in these pulmonary nodules to assist in these management. Welcome, Tammy. Pleasure to meet you and have you here today to do this discussion.
Thank you very much. Thank you for having me.
Why don't we get started? Let's talk about lung cancer and why, nodule management and lung cancer screening is super important.
So the first slide talks about the importance of lung cancer and the fact that it's the number one cause of cancer deaths in the country. It outpaces colorectal, breast, and prostate cancer combined. So that is what shows on our first slide. But it also talks about the fact that lung cancer is found late in diagnosis. And the problem with that is,
so true.
It is, there's no symptoms right away. And so, especially for me following these nodules, a lot of people are hesitant to come in because they say, I feel fine.
Yeah.
But the issue is you don't have symptoms until it's late. And so that's why I try to explain to people that it's important to start early, find these things, and follow them over time to make sure there are no changes. And in our program actually came about because our health system was concerned about this late stage diagnosis in our county. And I'm proud to say that we've turned that around basically because we are so diligent about watching nodules and they're intervening early or following over time to make sure that everything isn't going to change and we can discharge those patients.
In your practice, how did you start that? Like, was this something that you knew right away that you were going to, develop a program for these patients, or was it something that there was a need for that you applied for? How did you get into that?
So it was actually a need that they found. Our actual hospital board decided that it was going to be a focus right in the middle of COVID, interestingly enough, and they created my position. I have a background in thoracic surgery, and we have a very visionary thoracic surgeon here at Frederick Health who had started this sort of a grassroots process on his own because he knew that there was no one out there following these nodules. And he very quickly became busy with nodule surveillance and was able to create my position. So I came on back into thoracic to start this lung nodule surveillance program in addition to trying to boost the lung cancer screening program.
Yeah, and surveillance in itself is crazy. I mean, we opened it up for 1 month and it was like 800 CTs with nodules. And so, preparing yourself for that kind of volume when you start to open that up. I mean, I'm looking at your next slide where it says early detection depends on this management of nodules in these scans. So how do you get these scans through your institution?
So we have a process in place where within the institution, any CT, chest, abdomen, CTA that shows a lung nodule is actually flagged by the radiologist with an incidental nodule code. And then we are able to run that report on a weekly basis. Initially, we were sort of vetting everything and trying to figure out what the best size would be to follow.
Mhm.
And we finally settled at 6 millimeters, basically because of Fleischner. And, we will see any nodule. If I get a 2 millimeter nodule referral, I'll see that patient. But as
Yeah.
far as the outreach process, we've settled at about 6 millimeters. And
And do you pre-screen them for risk factors like smoking or age, coverage for these scans, that kind
yes.
of?
Well, not so much coverage. We have a pretty good process in place for the uninsured that the
Mhm.
the hospital has a financial assistance plan that we can get them into.
It's great.
I vet all of those patients, and so if it's somebody that's on the cusp and they're at about 6 millimeters, I'll look at smoking history and all of that stuff. And even if it's to see that patient and say, "Hey, we need to repeat this CT in a year," or talk to the primary care provider or the ordering physician, whoever it may be, to say, hey, this patient has risk factors. And so per Fleischner, we ought to repeat this CT in a year.
Mhm.
They can either do it and send to me, or they can do it and just, send me a message, say, hey, that CT is done. Can you take a look at it?
Yeah.
Uh, because this is all I do, I have the time. A lot of the people listening are managing pulmonary disease and all and other
Yeah.
things. But, a dedicated nodule coordinator and an APP to see these patients
It's
is
essential. I love that.
beneficial. Yes, it is. And, for me, they call me the lung nodule expert in our community. And it's funny for me to be an expert at anything, but,
Yeah.
it's,
Well, this next slide is so scary, right? Like 30% of all CAT scans will have some sort of pulmonary nodule, so
right,
which may or may not turn into cancer, right? There's 2 million lung nodules found every single year,
right,
and probably, they're being missed
right,
or not followed up on.
right.
95% of those are likely nothing, but if you miss that 5%, I mean, that can be life changing for patients.
I tell patients that all the time. This is something to know about and follow up on, but likely this is not a cancer. And we need to watch this closely to make sure that these things don't increase in size when they're concerning. And if you
Yeah.
look at the next slide,
Yeah.
there's a big challenge with this because we need to figure out when we do surveillance and when we do an intervention. The size of the nodule at uh, identifying the nodule is very important. Anything that is 10 millimeters, the size of a Cheerio, if we find a cancer at that time, the overall survival is 92%. But if you find it later, say the size of a banana at 30 millimeters, the survival rate, the 5-year survival rate goes down. And so the challenge that we have is how do we follow these nodules so that we are not missing something, but we're also not doing a procedure on someone that doesn't need it.
Yeah.
Um,
Well, not only that, with procedures, you can only do so many robotic bronchoscopies in a day, right? And so I know our wait is like 3 weeks to get a procedure in, and
Right.
these patients have already probably waited to get that to get diagnosed with needing a procedure. And so how can we facilitate getting procedures to people who really need them is
Right,
essential
exactly.
too.
Triaging those that need it now versus need it later, or don't need it at all, is very important, especially like you talked about for the
Yes.
bronchoscopy time and, patient cost and risk factors, all of that stuff.
Yeah.
So
Now, take me through a patient that let's say, has, a 10 millimeter nodule. How are you going? Take me through a patient of how you look at them and go through the process in your practice.
So if it's found on that report or if a consult, a referral comes in from a provider, I vet all of those patients. I look at the nodule, I look at the whole CT, I look at the patient history to decide how soon that patient needs to come in. Now, the nice
And
thing is,
I want
go
to
ahead.
interrupt for a second. What kind of history would flag you that this needs other workup?
Smoking history, family history of lung cancer, exposure history. One of the things that gets me, we have a lot of firefighters, and they're not first on the list, but they have a lot of exposures. And so those are some, patients that I look at to say, oh, we need to be seeing them sooner. Age is important. we're not going to rush to a 99-year-old who's going to tell me, I'm 99, don't need to come in to see you. But a lot of those things, and cancer history, we worry about metastatic disease in the chest.
Yeah.
And so those are all things that sort of put a red flag up to me to say, no, we need to get this patient in the next week or so and not wait, to the next available appointment 3 weeks from now. So,
Yeah.
and then I do look at the Mayo risk calculator to say, what is the risk of malignancy in this nodule? And I put this patient with me, who potentially would maybe just do some surveillance or more testing, or one of our interventional pulmonologists who may go straight to biopsy based on clinical suspicion, some further testing, PET CT, that sort of thing. We have 2 great interventional pulmonologists in addition to my thoracic surgeon who does ion navigational bronchoscopies. So that's kind of my role to begin with, is to triage those patients and put them not only in the right time frame, but with the right provider.
Right. But there's always those patients that are kind of the in-between, right? That may not be a great candidate for bronchoscopies, or may not be low risk to do surveillance, but not super high risk for procedures. So tell me about these intermediate patients and what you do with them.
So those are the ones that we use the blood test for. We do use PET CT as well, but we use the Nodify blood test to help risk stratify those patients for decision for biopsy versus surveillance. It's been very, very helpful for us because, like on the next slide, 62% of biopsies are performed on benign nodules. So we don't want to be doing that, but we also, and 34% of surgeries are performed on benign nodules. We certainly don't want to be doing that. But the other side of that coin is CT surveillance is conducted on 17% of malignant nodules. And so, time is of the essence when we're talking about lung cancer, and we want to make sure that we do everything we can to avoid either overtreatment or undertreatment in this case.
Yeah, definitely.
So the Nodify blood test is what we use to help us determine how to follow these patients. I tell patients all the time, this is not a diagnostic test. This is not going to tell us if you have lung cancer. What it's going to tell us is what your risk of cancer in this nodule is by using 2 different tests. The first test is called CDT, and it is the cancer detection test, which uses a autoantibody in the blood specific to lung cancer to determine if the patient is at risk for lung cancer. If that test is positive, then we don't even do the second part of the test. That is when we start to consider either biopsy or very close surveillance, because those patients are then considered high risk. If the CDT or the cancer detection test is negative, then we would go to it reflexes to the second test, which is the XL2, which is basically measuring a ratio of 2 proteins to help us determine if this is a benign process. And so that's basically how I explain it to the patients at their level, so that they understand, what we're going to use this test for. And it does help us with peace of mind for the patient. If, when I tell a patient, oh, you've got this nodule, but we're going to repeat a CT in 3 months, they're like, oh, 3 months.
They're panicking for the entire 3 months.
Exactly.
So do you, you get that at the first visit with them, the blood test, to kind of help with the decision-making? And does patient preference kind of play a role in that? Like if they are leery about procedures, and they're still kind of in that higher risk category, does that kind of help with the conversation, or do you still,
Yes. And the interesting thing is a lot of them are educated on radiation exposure as well. So if they come in and they have an 8 or 9 millimeter nodule, one of the radiology departments that our patients go to will recommend a PET CT, but it's a little bit small, in my opinion, to do a PET. And so, I'll tell them we can order the PET because that's recommended on the report. However,
Yeah.
that's radiation exposure. It may not help us. And
Yeah.
so that's a lot of them are very hesitant to get another x-ray. And
Yeah.
so I'll
Well,
say,
especially
okay,
if it's not gonna be helpful in driving that management, right? Like, if it's too
exactly.
small, the pets are useless to us,
Right.
right?
Exactly.
And so,
Yeah. I
I
say,
definitely
if
see.
a false negative doesn't make me feel any better on an 8 millimeter nodule, but
Correct,
a
correct.
negative Nodify does make me feel better,
Yeah,
and so that's eh, people that are hesitant for biopsy, hesitant for more X-ray exposure, hesitant to wait 3 months
yeah,
to get another CT. This is very helpful in that sense, and we get the answer back pretty quickly.
yeah.
And so that's why it's been a great tool for us to use to help figure out who we need to follow and who we need to biopsy.
What is the turnaround time for the test in your experience?
So CDT is 24 hours.
Oh, wow.
And yeah, and XL2 is usually about 5 days, business days. We get those results pretty quickly. We had initially done we sent everybody for home phlebotomy, which was convenient for
Oh,
the patients. But it does delay things a little bit getting that
set up.
phlebotomy scheduled and, but now we have switched over to having the kits in the office and sending our patient. We have a lab downstairs because we're in a cancer center. So those patients go right to the lab and get that done right away. So I'm finding that those results are coming very quickly. And it's nice because I can call the patients usually within a week and say, hey, everything looks good. We'll plan for that 3-month follow up. Or, you know what? We were kind of surprised with this. That CDT is positive. I need to bring you back in to talk to one of our interventionalists about maybe getting a biopsy.
Yeah.
Doesn't mean they're going to do it. But I do want you to have that face to face with them to decide if they need it now or they are comfortable watching for 3 months.
I can see how important this test would be in those areas where there's like histo and coxy and blasto, where there's nodules all the time, right? And it's like surveilling these can be quite cumbersome, as you know. And
Right.
then again, putting them into these procedures for these benign nodules that can be
Right.
super helpful to,
Right.
you know, like de-escalate that process.
Yeah. And what we found when we use Notify is that we can stratify those people. Everybody sort of sits in that middle line of the 5%, more than 5%. But when we do the Notify blood test, we'll have a lot more people that are either low risk, much, much, much more people that are low risk. But those high risk people we identify very quickly and can, biopsy.
That's great.
For the most part, it goes to biopsy. Sometimes there is surveillance depending on, patient comorbidities and that sort of
Yeah.
thing. But for the most part, that CDT will lead us to a positive CDT will lead us to biopsy.
Now, did you find it difficult to get the blood test integrated into your health system instead of the home sampling?
There were a little bit of difficulties, mostly because we have Expanse, and so it's a Meditech, and so it's not the most user-friendly process. I do think, anybody that has Epic, I think it's already,
Integrated?
exactly, and so,
Okay.
I think that depending on your EMR, we had a couple of, issues with, billing for, the blood draw and that sort of thing, but most of those kinks are worked out.
Okay.
And so for the most part, it was a long process, but I think it's that way, with any integration. And it was a wish list of Dr. Smith's for a long time. And so I think it's probably been about 3 or 4 months that we've been doing it. And, for the most part, it's been relatively smooth.
And what about
Initially,
insurance coverage? No problems with
no
insurance
problems with
coverage?
that. Yeah,
Oh,
so
wonderful.
far, and the company works very, very well with those patients that are not covered by insurance. And so patients ask me all the time, but I'll say I've not in all the tests that I've ordered, I've not had any issues. And so that's why I'm comfortable ordering it because I don't want to strap you with a bill.
Yeah.
As much as I think this test is useful, I don't want you to have to pay for it. And so,
Yeah.
um, you know, It's interesting. My mom had a lung nodule. It's quite large, actually, and she had it done. And at the time, we were doing the home phlebotomy, and she just, she said it was great. I sat in my recliner. She came in. She was lovely. She drew my blood. She was gone.
Nice.
Um, and then she saw an EOB, and she said, "Oh my gosh!" I said, but just wait. You're not going to get a bill." And she was, very happy. She never had
That's
had.
wonderful.
Yeah, yeah.
And then, so obviously, this blood test has been tested, right, to look at its utility and specificity and everything, and helping to reclassify these patients. And so, tell me about some of this like national data that has been collected with Biodesix.
So they've had a lot of different studies done, and for the most part, everything looks good. There's really no risk to it, and so we don't have to worry about that. But what it has done is reclassify those patients that are sort of midline with risk of malignancy, either into low risk. If you could, there's a good slide right now, sort of showing how it was sort of this bell-shaped process, and it is turned into more of a obelisk because you have fewer patients with high risk at about 5%, and then more in the 40% that are down below the 5% risk. And so those, what it showed us is that we really can stratify those patients for next steps based on what we see on the blood testing.
Excellent. Yeah, and again,
Um,
getting those patients to procedures, because it is essence of time to getting them. It can be a curative process when the nodule hasn't spread, or stays a specific size.
mm. And this next slide shows our workflow algorithm at the office. Dr. Smith has, years of experience with this behind him. And so he has really sort of worked out a great process for larger nodules or smaller nodules, depending on what the patient presents with.
Mhm.
So anybody, I'll walk you through this because I think most people can't see this. I
Yeah.
would recommend, if you can, looking at this when you get a chance, because it really is very helpful. So anybody that has a nodule greater than 10 millimeters or is clinically suspicious gets a PET. They also get Nodify. And so if the PET is positive, on the right side, the left side of the flow chart, if the PET is positive, then we look at Nodify. If CDT is positive, the patient is sent for biopsy much sooner. Uh, when they do the biopsy, they will probably do more passes, and he may even consider single lung anesthesia, where he goes, does frozen sections and goes right to lobectomy if needed. The If CDT is negative, then XL2 is the next step. And what I tell providers that I'm talking about the results is XL2 is sort of on a spectrum of likely benign or indeterminate. And based on where the patient falls on that spectrum, helps us determine how to follow that. So there's a nuance to that when you order the test, you have to kind of get used to, but it's pretty straightforward. And this is very helpful. So anybody on the indeterminate end of the spectrum, we watch a little bit more closely. We either biopsy and do, more passes than might be in, normal. Or we may just watch them a little bit longer, depending on where they are on that spectrum.
Mhm.
And that's all for a positive PET. If the patient has a negative PET and Nodify is done with a CDT positive, we go to biopsy. If they have a negative PET but indeterminate, we might say, you know what, let's biopsy it, or let's follow this patient for 3 months. The important thing is anybody that is likely benign with a negative PET, we follow them per Fleischner guidelines.
Got
But
it.
depending on what we see on the rest of the Nodify results, we may follow them more closely. Somebody that has an indeterminate or a equivocal XL2, I might say, you know what, I'm not comfortable with a 6-month follow-up. I'm going to do a 3-month now. If everything looks okay and it's unchanged, then I'll go to 6 months. So we use Nodify not only for um, decision for biopsy, but decision for timing for follow-up.
How do you keep track of all these patients in your practice and where they are on the spectrum?
I have an incredible navigator. She's wonderful. And actually, that is one thing that anybody that is looking to start a nodule program, I think it's important that we, have a good team in place, not only the interventionalists and providers, but a really good navigator. Mine
Yeah,
has an imaging background. And so she is really, really crucial to have us, follow these patients. And, she helps me to risk stratify, but she also helps me on the back end to say, hey, this patient hasn't had their CT yet.
yeah,
We have a really good, she's very organized and has a great Excel spreadsheet. But we also have a good process in place.
great.
That's, very helpful.
Oh my God,
So,
coordinators that support your program are just so essential.
yeah,
In when you have a good one, it's like you don't want to lose them ever because it just
well,
keeps the workflow moving so that you can be efficient in your job.
yeah. And the important thing I tell my staff is, we have reached out to these primary care providers and committed to following these nodules for them. And
Yes.
so not only are we the ones that, need to make sure that these patients are following up, but we need to communicate with those primary care providers
Yeah.
to say, hey, this has changed, or hey, we're not able to get in touch with your patients. And so they know when they refer to us that they're going to get good care and continued care. So that's, it's all about the staff. So,
Yeah. Now,
yeah.
what about these nodules that are less than a centimeter?
So anything that's less than a centimeter, we generally do not order PET on
Okay.
unless they have positive CDT.
Got
And so, or an indeterminate Nodify, because like we spoke about earlier, it's hard to say a negative PET is truly negative in a small nodule. And
Yeah.
so the first thing we do with those patients is I will tell you how my process works. I tell the patient, it's 8 millimeters. I want to repeat the CT. You have risk factors, so I'm going to repeat the CT at 3 months. But I'm also going to order Nodify now. If Nodify is okay, we're going to keep with that plan. But if there's something that's changed, I will divert from that process and do something else. So a patient with a positive CDT, I call them right away and say, hey, we're going to get a PET CT. Or, you know what, I want you to go ahead and see one of my interventionalists to make sure everything is okay. But if we get that PET and the PET is positive, then they go to biopsy. If the PET is negative, we may continue with that 3-month CT based on clinical suspicion. But everything sort of works, the three together, the initial CT, Notify Lung, and that PET to make the decision about what we do next. And so a negative Notify with a less than 10 millimeter nodule, we follow per Fleischner. I shouldn't say negative, likely benign Notify. But anybody that falls within that 5 to 20%, so their risk reduction has gone down from Mayo, but not to a point where it's likely benign,
Nothing. Yeah.
then we may order PET based on, what we see on let's say a spiculated nodule or a
Yeah.
family history of lung cancer. Then we may order that PET. Or I may say, everything looks okay, but I may do a 3-month CT and then another 3-month CT, depending on what we see. So it all really depends on, that patient as well. But again, we use Nodify to steer the process in addition, and I tell patients all the time and other providers, this is a tool to help us, but we still use our clinical suspicion. We still use all of those risk factors that we implement, that we put into the Mayo risk calculator to decide all of this. It's just another tool in our toolbox to help us determine how to follow these very difficult nodules.
Yeah. That's awesome. You guys have such a great program there in Maryland. And, it's just great to, see the integration with coordinators and APPs and this multidisciplinary approach to really kind of help these patients out.
Dr.
Pretty,
Smith has a great slide in his presentation that shows the shift from 2019, before we started this lung nodule program, to 2024, I believe it is, and the shift of stage of diagnosis of lung cancer. Um, it is amazing how we have been able to, with lots of work and lots of focus, shift to early detection, in stage 1 and 2 in our community, which has made a big difference.
I'm just so shocked it took this long to get here, right? I've been in pulmonary 23 years, and it's just like when we were first diagnosing cancer from these nodules, it was so late stage, and it was like the patients were already symptomatic, and like the treatment for it was so invasive, and mortality was so bad. And now with immunotherapies and targeting genetics and everything, we can diagnose sooner. And with these
Yeah.
programs and community outreaches, getting these nodules looked at and followed up on to prevent, end stage lung, cancer and palliative and hospice, really start to cure patients.
Yeah. I tell patients all the time, a lot of it is the smoking stigma, and they
Yes.
don't want to, come forward because they feel this sense of guilt. I've done this to myself, that sort of
Yes.
thing. And to me, it makes them great patients. I've done a lot of surgical subspecialties, but I love working in lung and thoracic because I think they're very special patients, and I think they need that care that,
Yes.
historically they have been sort of, well, they smoked, and that's why they
Yes.
have this. And
I
it really
always
does.
tell them it never used to be bad for you. Like they were smoking on
Right?
airplanes and in
Mm.
hospitals and all
Yeah,
the time. Like it never used to be bad. And so it's an addiction that
right.
you needed help with. And, this is what happens when we have these, things. So yeah, I think that stigma does reign home. But then you look at 10% of non-smokers get lung
Yes.
cancer,
Yeah,
which is even scarier.
yeah,
So it just
right.
drives home the importance of these programs.
Yeah, exactly. And
Especially, I mean, what a great time. August 1st was the new World Lung Cancer Day. And now we're getting into, lung cancer screening month in November. The Go to Lung Cancer Summit and in Colorado is coming up in October. And so it really is, I think there is going to be a big push also with Medicare and Medicaid and the community to kind of push for these types of programs that are comprehensive
yeah,
and run by us advanced practice providers.
yeah, yeah, it is. It's been, it's very fulfilling to be able to see this. And it's interesting. In 1 week, Dr. Smith did 3 lobectomies on 3 women who were not lung cancer screening candidates.
Yeah,
But they were identified with lung nodules through our program and had curative procedures.
yeah, it's great.
One in particular said to me, if you had not pushed me to come see you, you would be seeing me in 3 or 4 years with advanced lung cancer. So
Yeah,
it really does make
life
a difference.
changing.
Yep. Yeah. So
And
anybody that's out there looking to start a program, I'm happy to talk to you at how we did it. And, it really, it makes a big difference.
I love that. Well,
Yeah.
thank you for joining the podcast with us. I'm glad we got to meet and talk about it. We'll have to get together and talk about our programs together one day. And with that, I want to thank you all for joining the APAPP podcast today on incidental nodules and Nodify by Biologic. To claim CMEs for this podcast or any other podcast, please visit our APAPP website. If you would like to join my interventional pulmonary APAPP group, just email info@pulmapp.com. And yeah, we can connect and, move interventional pulmonary forward. So I hope to connect with all of you soon. Thank you so much.